Welcome to our TV network, your ultimate destination for all things exciting and essential. From mouth-watering food to the latest in fashion, health, education, music, movies, and news, plus thrilling sports and breathtaking travel. Our TV network brings it all to you. Tune in today and experience the best of every world, all in one place, rtv.network.
Hello, and welcome to the Coaxum Report. My name is Terry Coaxum, and I have a phenomenal guest that is on with me today, Mr. Thomas Johnson, Executive Director of ASAP 340B. How are you, Mr. Johnson?
I'm great. How are you doing?
I am blessed. Welcome to the Coaxum Report. So you can catch us if you're just tuning in. You can catch us on Amazon TV. You can catch us on Fire TV. You can catch us on Apple and Roku. And on the weekends, you can even catch us on Tempo. And as we're here, Mr. Johnson, you can also catch us on WSTX Bloomberg Radio. So I am super excited to have you on. This has been an interview in the making.
That's right.
And so I'm excited. So the Coaxum Report is really about bringing on industry leaders such as you to talk about your barriers, your best practices, and big ideas. Our show is an international show, so folks are catching us, all over the world. Actually, I had one of my interviewees came on, and he got a text from an email from Nigeria telling him they saw him on their TV, and someone else I know was supposed to write me a check for a 501c3 and found himself in St. Lucia and sent me a picture asking me why was I on his TV. I said, that's a reminder, write the check.
Right.
So, don't be surprised if folks reach out to you and tell you they saw you on the Coaxum Report.
Okay.
So I just want to really just understand a little bit of the landscape of ASAP 340. But before I get there, I just want you to tell me a little bit about Thomas Johnson. How did you get to where you are? Why you do what you do? And then we'll talk about some of the barriers, because there's a lot of barriers to the industry that you're in. We'll talk about some best practices and big ideas, because I love to end with solutions. Folks are listening to you. They want to know how you do it so that we're able to move forward on all the industry levels. So talk to me about who you are and how you got to where you are, Mr. Johnson.
Sure. Well, I'm a native Washingtonian, born and raised in D.C. Graduated from Howard Law School and also Tufts University, and really wanted to try and be an advocate for those that can't speak for themselves.
That's right.
There are many ways to be an advocate, not just in the courtroom, but also in the area of public policy. Many years ago, after serving with one of the DC City Council members, I got a job representing physicians in the Washington, D.C. area as a lobbyist. And I have gone to represent hospitals, managed care organizations. I've worked in the population health space, represented the health insurance industry for 9 years. And now that's led me to this coalition that I represent.
Okay. So for those that are just hearing about ASAP 340B, tell me a little bit about the coalition that you are a part of, and a little bit about some of the work that you're doing, because you're doing some phenomenal things. And I think the one thing about the health industry we understand is there are some disparities. And so we need folks that are really standing in a gap to help us get through some things. I had the pleasure of working with Sickle Cell Thalassemia Network, and we did a legislative breakfast yesterday, and it was absolutely phenomenal. We have some great
Wonderful.
legislation coming out of New York. One piece of legislation with Mercedes Nassis, and Mercedes, she used to be a nurse, and so she understands some of the disparities in the ER. And so she wrote legislation that says that when individuals are coming in, everybody should be treated with dignity and respect, right?
That's right.
And
That's right.
then, looking at the DOE and those with sickle cell as a trait that are in DOE, and just seeing how we can help them get more educated, work for them, as far as advocacy is concerned. But I think the one thing, Thomas, that stood out to me most was I had individuals that were on my panel that I had no idea had a trait, the sickle cell trait. No idea. Some of them said that it was in the back of their mind and they hadn't thought about it. And it was a powerful legislative breakfast. And you're
Yeah.
standing in the gap all the time. So this is it. This is just something that you're doing. But for those that are not familiar with ASAP 340B, I want you to kind of really give us an idea of what that is, and then how you're able to move it forward for those that are in need.
Sure. Well, we have been around for about 2.5 years, and we're a coalition of 41 national organizations that, while we're supportive of the 340B program,
Mm-hmm.
we have some concerns about some of the practices that we've heard about that we don't think are in the best interests of patients,
That's right.
that certain covered entities have engaged in.
Mm-hmm.
And there have been news reports about some of these practices in the New York Times and the Wall Street Journal. There have been reports about these practices from the Government Accountability Office and the Congressional Budget Office. Um, and there are different types of groups in our coalition, including patient groups, community health centers, physician related groups, nurses groups, groups that represent people of color and their interests. And so we're supportive of the program, but some of these practices need to be addressed by Congress to make sure that the program really continues to serve the underserved.
So then what is, just give us a brief, 3 points of what is the 340 program, why it was originally created, and who was it meant to benefit?
So the program was created a little over 30 years ago.
Mm-hmm.
And essentially, what the program tries to do is to make sure that certain types of providers, um, hospitals, community health centers, HIV/AIDS clinics, amongst others, are able to receive drugs for their outpatients at a discount.
Mm-hmm.
And so they are able to provide those drugs to the patients that they serve, to the
So
communities that they
accessibility,
serve.
it's about accessibility.
Absolutely.
Okay.
And the drugs are generally, for this year, provided at a 59% discount of the acquisition price.
Okay.
So that's a substantial discount.
That's right. That's right.
Um,
That's over
and
half.
absolutely. And the good thing about it is that um, the way the program is supposed to work is that the provider can actually then bill either Medicaid, Medicare, or a private carrier the full acquisition price
Mm-hmm.
and
Mm-hmm.
actually keep that revenue.
Wow.
So that allows them to stretch out their resources and
Okay.
serve the underserved population around the
Okay.
country.
Okay. So it's supposed to benefit the underserved population.
That's right.
That's what the program is supposed to do. So what is one of the biggest breakdowns or barriers and how the 340B operates today from the perspective of providers that you mentioned, the pharmacies, the manufacturers, and the patients?
So one thing that's happening is that the statute is not specific
Uh,
as to what that drug can be resold for. So instead of hospitals specifically reselling that drug that they acquired at a discount,
mm-hmm.
instead of selling it for the acquisition price.
Mm-hmm.
A number of them are actually marking up that drug at a
Whoa.
500 to 1,000%
Whoa.
mark and
Wait, hold on.
billing.
Pause 1 minute. So I just want to be clear, and for those that are listening in, because this is really, really important. We all know that healthcare is expensive, medication is expensive, but you're saying that they're getting it at this 59% discount, and you're talking about marking up 500 to 1,000%. That's huge.
That's
That's
right.
huge.
And we've seen a number of studies that show that that's happened. The statute does not prohibit this. So
Wow.
once again, what we're doing is we're talking about a practice, and
Hmm.
we're not talking about skirting the law.
Wow.
And one of the things that we want to try and do is make sure that that practice doesn't take place,
Hmm.
especially for those who are going to covered entities, that they aren't overcharged for what's supposed to be a program for the underserved.
That's right.
Um, I,
Mhm.
I was on Capitol Hill today giving a presentation to a group about the program, and there's an example that was pointed out in the New York Times in January of this year,
Right.
where a woman went to a covered entity, went to a hospital, that's a 340B hospital.
Hmm.
Um, the drug that she used for breast cancer cost $5,000. They
Whoa.
acquired the drug at $2,700. They then billed Medicaid to $22,700 for the
Wow.
drug. They received $10,000 from Medicaid, so they've already profited.
Right.
And then they actually turned around and
And sued
sent
her.
a bill to the patient
Wow.
for $2,700.
Wow.
So
It's
that
unconscionable. It really is. Yeah.
it really is. But again, the statute is silent as to that type of practice. So that's one of the things we want to try and do, is to curtail that type of activity from taking place.
So then what do we do with strengthening the statute and making, because we know the intention was to give access, right? But it's not doing that. So now what do we do as a people? Because first of all, this is a huge problem across the board, no matter where you live in this country, right? Because unfortunately, my mom is right now experiencing, she had lung cancer. And so
Hmm.
thank God for New York. New York is amazing. She did some proton treatments. Sloan Kettering is like absolutely bar none. Basically showed up, just covered her coverage and took her coverage and made sure that she felt really good about where she was and what she was doing. And so it didn't cost us a lot. So what do we do about folks that may not have a Sloan Kettering or a proton treatment center? They treated her for 28 days straight and her mass shrunk. So
Hmm.
literally she is getting her life back, right? So what do we do for individuals like the one that you just described, where they pay $2,500 or so dollars, they charge $5,000, they charge the Medicaid 22,000, and now you're suing her, even though you already got your money, 3 times over. It breaks my heart, because again, when you have a family member that is in the healthcare system and is experiencing health concerns, you realize there's a lot of money that you're paying. When I worked in Chuck Schumer's office, one of the things that we were able to work on was the healthcare bill, right?
Hmm.
And I had, when the nurses came in and the doctors came in and the patients came in to have real world conversations with us about why they needed health coverage that worked. One stood out to me more than most, and this was a student at NYU, and she did it all right, right? So she did everything she needed to do. She saved her money. She was really frugal about it, and she was coming home from work one day. She stepped off on the curb and got hit by a car.
Hmm.
It took every savings that she had for her health care. It took everything that she had to get back to where she was. And she, at that point, had no money. And she did everything right. So we understand that we're one mishap away from being bankrupt, basically, when it comes to healthcare. So what do we do to strengthen that statute to make sure that it actually is doing what it's intended to do, which is to give access to individuals that would not have access to it.
Well, speaking to the example that I mentioned, one thing you can do is to adopt what community health centers do in this case. And that is that they have a sliding scale fee for those that they serve in this program. And that sliding scale is much, much lower than the example that I just quoted to you.
Okay.
Okay, so that you can see
So there
that.
are solutions. There are solutions to this.
Absolutely. And community health centers are covered entities under this program. And we think that all covered entities should be able to follow the example and their lead with regards to that type of patient. I would say, generally speaking, we need to have some transparency in this program. There are no transparency requirements for reporting what hospitals in particularly are spending dollars on.
So transparency is important. So we're gonna put a pin in it right there, because that transparency and that sliding scale. We got to take a quick commercial break. We'll be right back, because I think this is really important information that we need to share. We need to get it out there. We're gonna take a break.
Absolutely.
Thank you.
Reimagine a world where the Caribbean is seamlessly connected, where our people, our cultures, and our economies move freely across the islands. This is Connect Caribbean, more than a ferry service. It's the heartbeat of a new era, an era where economic opportunities expand, where trade flows freely across our seas, and cultural exchange flourishes. We are linking businesses, empowering communities, and reigniting the hope for a truly integrated Caribbean. Together, we're shaping a brighter, more unified future for the Caribbean. Connect Caribbean, connecting our islands, our people, our future.
TravelShare. It Marketplace is an innovative, dynamic, user-friendly, and fully comprehensive global travel marketplace, featuring all Caribbean islands as a premier destinations. TravelShare. It Marketplace featured daily travel news, arts, culture, events, travel weather news, individuals' remote work, flex time, paid time off, family leisure time, and travel deals to better connect the U.S., Caribbean, and the Americas worldwide. So no matter where you want to travel in the world for work or leisure, working remotely or on vacation by yourself, with friends or family, whether by air or sea, TravelShare. It Marketplace makes it easy to get you to your destination. Book now at www.travelshare.com.
For thousands of years, humans have searched for better and faster ways to trade with one another across the globe as a way to improve our world. And in that time, the principles of commerce have remained the same: to finance transactions, to mitigate risk, and to connect buyers and sellers. But what has changed is that the world has gotten smaller. Barriers to entry are declining, and technology is bringing the world forward into a new economy. Throughout it all, Coaxum remains a constant partner. We're here to guide and support you through this new frontier of trade, empowering U.S. businesses to export safely and confidently. In fulfilling our mission, we'll help you navigate and overcome new challenges successfully. Together, we'll help make this world better. Whatever the future holds, no matter where we go or how we get there, Coaxum will be along for the ride.
Third Wall Street is a new emerging global capital markets formation and structured trifactor financial hub at the U.S. Third Border in St. Croix, U.S. Virgin Islands, in the Caribbean and Latin America. The new Third Wall Street is the home of the Alexander Hamilton Financial Center and named in honor of Alexander Hamilton, an American founding father, first U.S. Treasury Secretary, and architect of the U.S. financial system and modern America. Third Wall Street is located in a U.S. National Heritage Area Opportunity Zone, and the boyhood home of Alexander Hamilton in St. Croix, U.S. Virgin Island, connecting 3 financial hubs in the Americas by way of new innovative financial technology and markets: New York Wall Street, Wall Street South, Brickell Avenue, Miami, and 3rd Wall Street in St. Croix, U.S. Virgin Islands, and established the new Caribbean America's Single Economy Zone, developed by SETI Case Capital Markets. 3rd Wall Street will transform financial markets, improving access to capital worldwide. Visit www.thirdwallstreet.com to learn more.
Thank you. Welcome back to the Coaxum Report. Consider you just joining. I'm on now with Executive Director Thomas Johnson, ASAP 340B. You can catch us on WSTX Bloomberg. You can also catch us on Apple, on Fire TV, and on Roku. And we're having some really important conversation around 340B. I think, Thomas, first I want to thank you for just sharing this critical information with us. We talked about some of the barriers. We talked about the intent of the 340B program and how it was originally created and how it was supposed to be giving access. We also talked about some of the barriers to the program. We talked about, the lack of transparency and how to strengthen the statute. But more importantly, we started talking about some of the solutions early on. You started telling us transparency was a part of it, but also having these sliding scales. But I want to step back a little bit because I want folks to really understand why this matters. So 340B is supposed to protect the underserved, which is what you explained to us early on. It's supposed to save lives and, like I said, expand access and keep families from this financial ruin. And an example that you gave where this individual, there was a 59% discount. She was given this $5,000. She was charged $5,000 and then ultimately $22,000. And though they got $10,000, they still were going after her for additional money. And that, again, can put you in financial ruin. So the barriers are clear, right? So patients are still being billed, sometimes after providers have already profited, which is what happened in the example that you gave. The solution is practical. Adopt a sliding scale, which is what you started alluding to use successfully. Other community health partners have already used it. So these are guardrails that are important. Adding the transparency, the guardrails, building partnerships, right, with practicing providers to make sure that we're able to I'm so sorry. This phone never rings. And of course, now it's going to ring while I'm on a TV show. So I apologize for that. And so I want to talk a little bit more because this isn't just a New York problem or a DC problem. This is a problem that's around the world, right? And we also know financial ruin through not really, you get an illness or you're experiencing an illness and you are now faced with this huge bill. What you should be focusing on is your health, right? You should be focusing on your healing. And instead of that, what you're focusing on is paying a bill that is, like 3 and 4, and in this case, even almost 4 times as much as it should be. So these practical guardrails that protect these patients, while they still maintain a financial lifetime of 340B practices, how can these partnerships, which is what you started talking about, the partnerships with the hospitals, the community pharmacies, the local providers, strengthen this program? So we talked about a sliding scale, right? So we know this works, right? So that is important. We started talking about transparency. We know that works, making sure that we understand, right? And I want to talk about some of these partnerships because I think that is key, even with what we were doing yesterday with the legislative breakfast, having a partnership with the hospitals, right? having communication with the first line nurses and advocates that are in the emergency room when that sickle cell patient comes in, understanding that they're not drug seekers, that they're in crisis,
Mhm.
right? Those partnerships are what make a difference in making sure everyone is treated with dignity and respect. So these partnerships that you started describing, I want to know a little bit more about them because, like I said, we're listening across the country right now, across the world, to this conversation that we're having about 340B. How can we strengthen these partnerships to ensure what 340B was supposed to do with giving access is happening? And if it's not happening, then where do we turn? Who do we talk to? Where should we be, showing up as advocates to strengthen what you're already doing?
Well, I tell you this, the program accounted for about $66 billion in purchases in 2023.
Whoa. Okay.
Okay. It's the second largest prescription drug discount program in the country, second only to Medicare Part D. 87% of the purchases made in the program are made by hospitals. Yet, hospitals are not required,
Wow.
because they aren't HRSA grantees, they aren't required to report on the revenue they receive or what they spend these dollars on, like
Wow.
the other HRSA grantees are, including community health centers. So without that mandate from federal law, hospitals have been reluctant, to say the least,
Wow.
to report on what they're spending these dollars on. And so we have seen instances where hospitals and hospital systems have used 340B dollars to spend money on naming rights of stadiums, to spend money on a Super Bowl ad, and to spend money on paying the salary of a football coach, much less capital improvement projects,
Hmm.
for those hospitals.
Right.
And none of those dollars are going towards patient care.
And that's ironic, right? Because we're talking about hospitals, which are emergency rooms, right? Which are places that are supposed to be first responders for your care. So how is it that they aren't required, to have the same transparency that these community health centers are required to have? And more importantly, they're seeing more value, which means that they're able, they can change this, right? As far as access, right? As far as affordability. Like this is something that can be changed very easily if they were required to spend these dollars where they're supposed to be intended to be spent and not on things that I don't know, brand themselves. I don't know. I don't even know what to do with that. So I'm
Yeah.
just, yeah, I don't know what to do with that. I'm just, wow.
Yeah. And I think, the issue here is this statute has been around for 30 years.
Yeah,
When it was first enacted, the program was relatively small,
right.
but over a 30-year period, it's grown.
That's right.
During the discussion around the Affordable Care Act, there were other types of covered entities added to the statute, so the more type of entities could qualify for this
Mhm.
discount.
Right.
But outside of that, none of these issues that I'm talking about regarding transparency, regarding spending money on patient care, there are other practices I can speak to that we think go against the nature of the statute and the meaning of the statute that are being engaged in. Again, they're being engaged in primarily by hospitals and hospital systems.
Hmm.
We are not saying that all hospitals and hospital systems are doing this, but a good
Right.
number of them are. Senator Cassidy from Louisiana chairs the Senate Help Committee, and he released a report in April talking about and outlining some of these practices that hospital systems like the Cleveland Clinic and Bon Secours down in Richmond have engaged in, which really go against the nature of the statute. But again, if the statute is not clear and if the statute is silent in certain areas, you know, and I know that there are smart people in the healthcare system and they will engage in a practice that they are not prohibited from doing so. And we think that's what's happened with this program.
So I think the amazing thing to me is that if all of the hospital systems did what was intended by the statute, we would change the whole healthcare system as far as access and affordability for the most vulnerable populations going through this health crisis in their lives. And so I just, I think that even listening to some of the numbers and reading some of the reports, it baffles me that a system that, especially the emergency rooms, I think about hospitals, I think about, New York, I think about Kings County, and I think about downstate, and I think about, Brooklyn, I think about the places that are hubs in our community when there's a crisis. When you are an emergency crisis, you're running to your hospital. You may follow up with your primary care physician, but you're going to go to your hospital first. And so they're like the ground floor for a lot of our, communities. And so it just, it disheartens me to understand that this statute could be used in this way. I think it should be clear. I know it should be clear. It should not be silent. And individuals that are engaged in these practices need to turn this around, because you are able to help so many more people if you use the statute for what it is intended to do. We talk about transparency. Technology exists, right? Data exists, reporting tools exist. What would you suggest would be something that you would use to help to make sure that we're tracking the challenges in the 340B system, so that we can turn this around relatively quickly and we can help strengthen the statute to be able to help individuals?
I think the reporting requirements issue is huge. I think that there's actually some bipartisan support for some type of reporting requirements for all covered entities under this program.
Mm-hmm.
If you don't have that, then a lot of these practices are going to continue.
Wow.
And, my opinion is if community health centers and HIV/AIDS clinics are able to report what they're receiving and what they're spending those dollars on, then there's no reason why these large multi-million dollar, even in some cases billion-dollar hospital systems should not be able to do the same. They clearly have the resources to do it.
Absolutely.
They clearly have the staffing to do it.
Absolutely.
Okay, they're much larger than some of these community health centers.
Mm-hmm.
Yet and still, the community health centers are providing that information and hospitals are not. So let's have the same standard applicable to every covered entity.
That's right, every covered entity. And I think that is the key there. So if Congress are listening today, what would one of the policy recommendations that you would want them to act on first? We're talking about transparency, we're talking about accountability, we're talking about making it applicable to all, right? So what would be one of the policy recommendations that you would want them to act on first? And then I want to talk about the ripple effect of our vulnerable patients after that.
Yeah, I think the first and foremost, is to make sure that reporting requirements are mandated for all covered entities.
Yeah, reporting requirements.
The second thing I would add is that sliding scale issue that I talked about should be mandated for all covered entities.
Okay.
I mean, those two things alone would address the needs of patients and would address the transparency issue that hovers over this program. Because once again, one group of providers representing 87% of the purchases under this program, they are not reporting what they're receiving and what they're spending those dollars on.
87% is huge.
Absolutely.
representing 87% of the that's a big number. So that in itself speaks to the ripple effect, to our vulnerable patients, our small community clinics, the families. If 340B fails to continue without accountability, right? So we're talking about reporting, we're talking about transparency, we're talking about being able to have this program do what we need it to do, especially for those in our vulnerable communities, giving them that access that they deserve. So if the reforms are not done right, which is what we're saying it should be, if the statute is not strengthened, if the accountability, if the transparency, if the reporting tools, what does the future look like for our neighborhoods?
Well, I would say this. If Congress does not pass at least those two measures, and there are other measures that could pass that would help this program, what's going to happen is that this program is going to become the largest prescription drug discount program in the country.
Wow.
It will be the largest in the next 2 to 3 years at this rate. This program is increasing in cost by over 20% a year. And that means that we are not going to have data on close to 90% of purchases under this program.
Wow. And so the neighborhoods that depend on this accessible, affordable care, we don't have data, then
we literally don't know what those hospital systems are spending dollars on. And we are going to continue to see Super Bowl ads from 340B covered entities.
wow.
For example, when that money can be going towards patient care. We won't see a drug that is acquired as a discount ending up in the hand of a hospital system for 5 times what they acquired the drug for
Right.
one person, instead of treating 5 people.
Right.
Okay, because there's no reporting on the information.
Right. And we
And I
need
can
to
tell
know we need to know what's going on with the money.
absolutely.
And that's how
I speak to not only healthcare related groups, but I speak to a lot of community groups. I speak to churches. I speak to patient advocacy groups, and I can tell you when they hear about these dollars and there is no accountability for what this money is being spent on, they're upset.
and they should be.
Absolutely.
They should be. They should be. I think that even like having this conversation out, which I think is really important. First of all, I want to commend you again for the work that you're doing. And having those conversations with our churches, having this conversation with our community leaders and community groups to know what's going on with the 340B program, to know what the intent of it is, right? But also to understand that there is no reporting and there is no transparency and accountability, and patient care should be first, but instead dollars are being spent on other things, right? So how do we get that to making sure that it's done, that it's doing what it's supposed to do? And you said it. We need the reporting requirements, right? We need to have transparency. We need to know where these dollars are going. We need to have the data. We need to have the data that is telling us where these dollars are going at. And we need those dollars to go towards patient care and not the other things that it's being used for. Because at this point, we don't even know, because there is no data, there is no reporting, there is no transparency. And I think it's really important for us to have this conversation at this particular time when people are not clear on what their next is going to look like. I mean, healthcare for me personally, it really made me stop in my tracks to really come up with a care plan that was affordable for my family to be able to move forward. So to know that, a trip to the hospital, where, the 340B were these discounts. And I think that's the first place where you got me when you said there's supposed to be like a 59% discount. They're getting a 59% discount, but yet they're charging this person $5,000, and then they're charging, Medicare, Medicare, $22,000. And after getting $10,000 and it only cost them $2,000, they're then going back to the patient and asking and demanding more money. And I think that is unconscionable. I think that that is where the buck stops. That's where
That's
we.
one of that's one of the reasons why the National Consumers League is part of our coalition,
Mhm.
because they follow very closely the types of debt collection practices that providers and hospitals are engaged in.
Right.
And that's why it's a priority for our coalition to see that those types of practices don't take place anymore, because we don't think that they're in the best interest of the patient.
We don't think they're not. They're absolutely not in the best interest of the patient. Again, this coalition, and you started out by telling me all of the partners that are part of it. And I think it's really important for you to be bringing together, leading this coalition, making sure that we are clear about what's happening with these dollars and demanding that patient care be put first and foremost when it comes to this, the 340B program and where the money is going. I think
Mhm.
that, this reporting system, and I go back to that because the technology exists. It's not hard to report anymore. Like, you can literally push a button and be able to see where all the dollars are going to. So having that requirement, having a statute be a lot stronger so that we can see where the dollars are going and making sure patient care is first, transparency, accountability, right? Accessibility to individuals in these vulnerable communities that need to have all of this in order to be healthy and to be treated with dignity and respect. And I think that's
And well, I'll say this also. Senator Cassidy launched an investigation into some types of these practices, and we released a report in April about some of these practices.
right.
And you know where he got the information from in terms of where some of these hospital systems received? He got it from their earnings reports.
Wow.
Okay.
Wow.
And, Senator Cassidy has said, 340B revenues should not be part of an earnings call,
That's,
for a hospital. That's
that's
what
right.
it's not supposed. If you can provide that information during an earnings call, then there's no question you can provide that information
Information doing
in
a
a
report.
regular report.
That,
That's
right.
right.
That's right. And I think that's spot on. That really is spot on. So I know, it's still, funny how time flies when we're having fun. The show is almost over. But I think that it was really important for us to have this conversation, especially as we're ending this year, to make sure, and I always say, without health, there is no wealth, right? So it's important for those individuals that there is this 340B program that is supposed to be accessible, that is supposed to provide the benefits to the vulnerable communities. And we need to make sure that we are at the forefront. You're already leading the charge, and I want to commend you for doing that. You're bringing together the coalitions are having the conversations and making sure that this is a top of the mind. But more importantly, you have solutions. And I think that that is the biggest thing that we need to have, like coming into this interview. I wanted to be clear about what the solutions are. We can talk about the barriers, and we did. We talked about
Mhm.
a lot of the barriers, right? And then we talked about some of the best practices. But we're ending with solutions. And so if there is, one thing that you want to be able to leave with our listening audience, because you gave a lot of information today and you talked about the sliding scales being a solution, the reporting being a solution, having transparency, strengthening the statute, having these groups come together, right, to make sure that patient care is first and foremost and not the back of the mind, before all these other things are being thought about. And then having the reporting is already available in the earnings call, so it can be available in a recording call. What do you want to leave with individuals that are listening to our show today and have heard about the barriers, the best practices, and now some of the solutions and the big ideas? What do you want to leave with them?
I think there are two audiences that they should speak to about 340B and the need for reform. One, speak to your elected official,
Mm-hmm.
especially at the federal level.
Mm-hmm.
You have a senator, you have members of the House that you can speak to.
That's right.
The other group that I would speak to specifically, if you go to the hospital, you should ask the hospital if they are a 340B hospital.
Wow. You can get
and
an
start
application for them, huh? That's good to
and
know.
and start to ask when you go to the intake person at a facility. Start to ask them, are you a 340B hospital?
Okay.
So hospitals can start to be aware that patients are becoming more aware of this program.
And understand the benefits of the program and what they're supposed to be. I think that's an excellent idea. So, and I always tell my students, I teach at Medgar Evers College, I tell my students about advocacy and being involved, because if you're not at the table, you're at the menu, you're on the menu. It's not that decisions aren't being made, they're being made. They're just not being made, they're not being made by you. So being, proactive, being able to talk to your elected officials, your 545 House of Representative members, or having your 100 senators, talking to them about this program and the benefits of it, and more importantly, asking the hospitals, are you in the 340B program? Knowing and understanding and letting them understand, what that
Exactly.
means and what it should mean as far as patient care, benefits, accessibility. So that's a great, segue and step into next. I look forward to coming back and having more conversation about this as we strengthen this statute so that we are able to put patient care first. And again, I want to thank you and commend you for the work that you're doing. And happy holiday.
Happy holiday to you too.
I'm glad this conversation finally got a chance to happen. And, when I'm in DC, I'll make sure I look you guys up and see what you're doing. Have a super amazing day on purpose. And thanks again for sharing ASAP 340B with us. Take care.
Thank you.
Bye-bye.
Absolutely. Take care. Bye-bye.
You too.
Welcome to our TV network, your ultimate destination for all things exciting and essential. From mouth-watering food to the latest in fashion, health, education, music, movies, and news, plus thrilling sports and breathtaking travel, our TV network brings it all to you. Tune in today and experience the best of every world, all in one place, rtv.network.